Beitsch and Dr. Whitworth introduce themselves and then move into our presentation. Dr. Beitsch, if you'll start.
Yeah, I'm Peter Beitsch. I'm a surgical oncologist. I used to do all kinds of surgical oncology, but now I just do take care of breast cancer breast patients and melanoma patients. Have been doing so for many years and part of TME. Pat, who's hopefully on. Walt, you introduce yourself. You're on mute.
Sorry, I was muted. Pat Whitworth, breast surgical oncology in Nashville, breast only since about 20 years ago. And I'm excited to have this opportunity to talk to the folks we know and folks we don't know about this sort of breaking news, headline news in the field of breast care and prevention of lymphedema. I'm particularly excited about it because I've been enthusiastic about this approach for many years, having seen what appeared to be very convincing results in my patients and in study after study that were based on historical studies. And then finally to have your strongly held beliefs confirmed with a randomized controlled trial is always gratifying. So I'm looking forward to what we're going to show today.
And today's emphasis really is on breast cancer related lymphedema, but in melanoma patients, we disrupt their lymphatics all the time. And I mean, other surgeons I've seen their patients get lymphedema. Of course, none of mine do, but I'm just kidding. Of course, my patients do, and particularly in melanoma of the lower extremity. That's been this technology's been a godsend for picking up subclinical lymphedema and getting those patients treated when they're reversible and not after they get a big leg. So that's.
Well, Pete, I'm kind of glad you said that. I know you were joking, but I think we have many colleagues, and in fact, I've heard some of them very, very good friends of ours and well-respected say, well, you know, I don't really think there's a problem with lymphedema. I don't think I have lymphedema anymore. I just do sentinel node biopsies, so it's probably not a big deal. So I think this evidence that we'll show sort of as a wake-up call to some of those folks.
That's perfect. Let's go to the next slide.
Risk factors, as most people know, and very familiar with most of these, although we were talking about this the other day, I think a lot of people are surprised about one of these, Pete.
Yeah, I didn't really realize that taxane-based chemotherapy could cause lymphedema. That was disturbing. And I would say in my breast cancer patients that are getting chemotherapy, boy, probably the majority of them get some Taxol or Taxotere. So yeah, that was, and I'm disrupting their lymphatics almost all the time with at least a sentinel lymph node biopsy. Now just the sentinel node biopsy by itself, Pat, does that cause this?
Yeah, in fact, in studies that look at sentinel node biopsy where patients had early disease and did not get, for the most part, did not get chemotherapy, sentinel node biopsy is associated with about a 6 or 7% risk. That was true in the Z10 study and Z11 study in the sentinel node arm. Next slide.
And don't forget B32, which had the very easy to measure water displacement method of arm swelling. So, well, there it is right there, Pat. You're right. 6% in just a sentinel node biopsy alone. But boy, you start adding on things. Now, I have previously declared that axillary lymph node dissection is dead. That may not be true, but so some people still get it. But I can tell you what's happening, at least in Dallas, is they took to heart that regional nodal radiation data out of Canada. And I see a lot of my patients getting that. Are you seeing any of that in Nashville, Pat?
Yeah, there's a very strong trend in breast care, and in particular with regard to radiation oncologists, to radiate more and more patients. We used to say you had to have 4 nodes or more. Now it's very strong consideration for 1 to 3. I think many people do differentiate between, you know, really lower risk cancers with either lower risk genomic profiles or lower risk traditional pathology, but a lot of our patients are getting radiated that never would have in the past. And I think we're moving now sort of the way things moved way back years ago in chemotherapy, toward finding out probably mostly biologic factors, genomic factors that identify folks who really don't need this thing, because the differences are measurable in some cases, but they don't apply to most patients. And so, you know, just like we were giving chemotherapy to everybody with a tumor bigger than a centimeter, and we learned that it was a very small minority of patients that really needed it using genomic testing. I think we're going to enter that era at some point, but right now we're in what otherwise would be an increasing risk for lymphedema era.
Hey, Pat, Pete, quick question. We had a question from the audience. Person asking, is advanced age a risk factor for developing lymphedema after breast cancer?
You know, Walt, it makes some sense. And we've all operated on those folks whose lymphatic flow seems really sluggish. You know, you do a sentinel node biopsy, and especially, you know, if you've ejected it shortly before the case, and those older folks don't seem to map as well or as vigorously. I don't have any data to answer that question. And I think certainly advanced age and high BMI might have something to do with that. Pete, what do you think?
Yeah, you know, and I agree with you, Pat. And, you know, that's as all things sort of degrade over time, I think you get some sclerosis of the lymphatics as we age, potentially just from, you know, doing their thing, which is, you know, protecting us from infections. But some of that gets inflamed, and then the sclerosis from the inflammation. So it makes perfect sense that increasing age would be an issue. Now, you know, we're trying to stop doing axillary surgery on those people, you know, more and more, unless they need it. So, you know, and radiation in some of those groups too. So, you know, it's all pointing toward individualization of care.
Yeah, you know, we'll talk about this later, but we're talking about risk factors now. We really, because of workflow considerations and because we want to give access to all the women that really can benefit from this, we test every woman that walks in the door. But at the end of the encounter, if I say, gosh, this lady was 80 and she didn't get a sentinel node biopsy and she didn't get any radiation and she just got a little lumpectomy, we probably would not charge for that. It didn't really change the workflow. It didn't really change how long it takes to get patients taken care of, but you can make that decision on the back end instead of sort of tying yourself in a knot trying to figure out who to do it on and who not.
Yeah, that
medical assistant.
Yeah, I think that's an excellent point, Pat. It just becomes a routine part of checking somebody into the office, right? And then, you know, if you go, oh, well, she didn't need one, and so you don't put it on the bill, you know, at the end because, you know, she didn't have any of the risk factors, like you said. So
it's not that common, but it's more common these days.
I tell you, it's way more common that it's missed than you.
You're right.
So Pat, you're not even going to care about the 6.3% for just a sentinel node biopsy alone, right? Who cares about that?
Next slide. Yeah, we've heard this from folks that we really respect and that are good friends. The same folks who mainly say, well, I don't see lymphedema anymore, and maybe they are just operating on 80-year-old ladies that don't need a sentinel node or radiation. But I don't know, Pete, to me, 6 or 7% is nothing. In fact, what we'll see is that with proper screening, a lymphedema prevention program using bioimpedance, you end up with about a 3% overall, and that includes a lot of high-risk patients. So my guess is you can go from 6% in this group probably down to 2 or less. It's certainly less than 3. And
yeah,
you know, that's my sister. That's what I want.
And you wouldn't accept a 6% cellular infection rate in a clean case, right? You'd be pulling your hair out trying to figure out why the infection rate was so high, and that's fixable in a short term without long-term consequences. This is something that has, you know, long-term, life-changing, life-altering complication rate. So, yeah, test people. That's the key. 6.3% is significant.
You know, I would love to see a survey of the folks that are on this webinar. We have quite a number, and I'd like to hear how many people feel like this is a significant number and they'd want to do something to reduce it. Next slide. This is the problem, and this is why you need something that detects lymphedema when it's subclinical. It's a study from the University of Kansas, and at stage 0 or stage 1, either 100% or 88% of patients could get their lymphedema problem resolved. Stage 1 is interesting because the elasticity in the interstitial compartment's intact, but it's intermittent. So if the patient comes in and she is in a period where she doesn't have any swelling, you're going to miss it. And that's why you end up in stage 2 with some of those folks, because their swelling isn't present when you're testing them, at least with tape measure. Stage 2, you've started to lose elasticity and you're never going to get back what you had to start with. Stage 3, the fluid's mostly replaced with fat, and that's really a problem. Some folks even do liposuction for these patients.
Yeah, I only have a couple of those patients, but it seems like they're coming in every other week, because every time I see them, I feel so bad about it because I caused it, right? Back in the day, back when we were doing dissections.
Well, we caused this. And then the other real sort of tragic, worst thing about this situation is a lot of patients that get blamed for their own lymphedema. People say, well, you shouldn't have picked up that baby. You shouldn't have carried that purse on your arm. Didn't we tell you? We warned you. It's your fault. And many women go around with this horrific regret. If only I hadn't picked up that baby. If only I hadn't carried that purse on my arm, which is absurd and something that hopefully goes away soon. Next slide. So this was the treatment for both groups of patients. It's funny when you say both arms because it gets a little confusing with this study, but in any case, both groups, if they triggered, and we'll talk about what triggered intervention in both sides, in both groups, this is what they got: early lymphedema treatment, which consisted of a compression garment, off-the-shelf standard compression garment, and gauntlet on the hand. They wore this for 12 hours a day, and that lasted for about 4 weeks. The treatment for chronic lymphedema, and in this study, if anybody went over 10% volume increase, they went on to complex decongestive physiotherapy. And man, this is something that, the more I learn about it, the more difficult it seems, because this is 24 hours a day, and they wear this until the maximum reduction has been obtained. And then if that's good for them, if the fluid is gone, that's great. They go on to a more standard sleeve, but if not, they go on to something like you've seen on the right here, either pneumatic pump or surgical intervention. A lot of people are beginning to report series there, which, hopefully fewer and fewer patients end up there now that we have the ability to prevent progression of this problem, or even infections and cellulitis.
Yeah, we did have a comment from the audience, Pat. This person has patients that had only a sentinel lymph node biopsy and have lymphedema, and the patients are upset, as you can imagine, that the surgeons told them that they had no risk of getting lymphedema. Yeah, that's obviously not true, and it's I usually warn them about that swelling, and that we can go into the workflow of it, but that they get notified that they can potentially get it, but because I tell them we have a program here to prevent it and to catch it early and to treat it if needed. So yeah, I think surgeons absolutely need to tell people that if you're disrupting their lymphatics, they can get lymphedema.
Well, the physical therapist that I worked with years and years ago, when we had first started using this for a couple of years, literally, and this is one of the things that pushed my bias in that direction. She said, we're not doing complex decongestive physiotherapy much anymore. I'm not using my skill set that I learned and that I felt was so important. But she was happy. She was glad not to be having to do that so often. Next slide. So this is the headline. This is the thing that sort of changed things in general from something where folks kind of believed it and incorporated it in their practice. And other folks said, I need to hear more evidence. This is as we mentioned, a prospective randomized trial, which is sort of changing everything in terms of reimbursement. And I think really in terms of convincing surgeons and radiation oncologists that this is something that is the right thing to have in any good best practices breast care practice. Next slide. Pretty simple question in this study was to compare screening for subclinical lymphedema with bioimpedance spectroscopy, LDEX here, versus standard volume tape measurements. And the funny thing about this is, wait till you see how the tape measurements were.
Yeah, I'm not sure it's standard volume. Tape measures,
It's a little different.
high level. It's yeah.
This would trigger an intervention, same intervention in both sides, and onto a CDP if needed in both sides based on volume over 10%. Next
Yeah,
slide.
so, yeah, both sides get the off the shelf compression garments.
So these were the inclusion criteria. If you had just one of any of these things on the list, and you only needed one of any of these particular in this list, then you were considered elevated risk for lymphedema and you were randomized or eligible for randomization. If you had sentinel lymph node biopsy with greater than 6 nodes and none of these other features, you could get in the study just with that, but that was really less than 2% of patients who had sentinel lymph node biopsy. Most of the patients had
80% of the patients had sentinel lymph node biopsy, but only 2%, less than 2% of that group had greater than 6 nodes. So this is just a regular sentinel lymph node biopsy plus something else, which, you know, if you're doing breast conservation, you're going to get breast radiation therapy. If you're needing chemotherapy, more than likely you're going to get a taxane-based chemotherapy. So sentinel lymph node biopsy plus others. So a lot of participants in the trial had more than one of these.
More than one. And they interact, as you saw in the previous slide, to make your risk go exponentially higher.
Right.
The patients were excluded if they had any of a number of things that might cause swelling or some sort of active medical device that might throw off the bioimpedance measurement. Implanted hip would not do it, of course. Next slide. So LDEX is now done with this SOZO technology on the left side. This is just our check-in area in the office, such as it is. The device used in the trial was the preceding device, the U400 device, but same LDEX technology, same LDEX measurements. Pete, what do you think about, is this how you do tape measure, how you did tape measure in your office?
Oh my gosh, yeah. So there is, yeah, of course, no, there's no way we could do this in the office in our workflow. There's just, it would be impossible.
Next slide.
Yeah. Oh, here we go.
So, so if a patient on the bioimpedance side, on the LDEX side, had an increase in their LDEX score of greater than or equal to 6.5, that was considered the trigger in that group of patients, and they went on to that 4 weeks of compression that we talked about. This technology is so sensitive because it detects very, very small changes in a way that the only other thing that's even comparable is a thing called pyrometry, which is not easily available and certainly not affordable in most settings. Next slide. So Pete, this is how you did it?
Yeah. Yeah, no, this you have to go to school for like 3 months to learn this technique, and yeah, it's incredibly cumbersome. You have to measure in 5 places. You have to pull the tape measure to the same tension. So so that circle is actually around a strain gauge. I mean, this seems absurd to me. But this is what it takes to get reliable, repeatable tape measurements of the arm. And I think 20 minutes is probably generous. I bet it's longer than that. And this would destroy the workflow in my office. There'd just be no way.
Right. You can't give women access to this if you want to. And we'll see, it wouldn't make any sense, as a matter of fact, since it doesn't really work very well. The other thing, each site in the trial had to get recertified that they were doing this meticulously every year that the trial was conducted. Next slide.
But I guess this was considered standard of care, I guess, Pat, right? Tape measure, but not this kind of tape measure.
Truncated cone, and I imagine there were, you know, very committed, obsessive compulsive folks out there who did it this way. But I think in most centers, you're probably getting some version of this that doesn't necessarily include a strain gauge. I think physical therapists were doing truncated cone, but as you said, this is just not something that you can make available to all the patients that need it. So the prevent trigger in this group of patients was an increase in volume of 5 to 10% over baseline. Next slide. Same intervention on both sides, 4 weeks, 12 hours a day, off the shelf. And this is the intervention for trigger in both groups. Next slide. So I'll just run through this really briefly. Patients had a baseline measurement before treatment, and that baseline measurement was done in both groups. So whether you're going to be randomized one way or the other, that was not known at that point in time. Post-treatment, patients got randomized, and so then they were referenced back to that original baseline measurement, either the LDEX they got or the tape measure they got. The folks in the LDEX group had the trigger we talked about. Tape measure group, same thing. If they went on to intervention, if their volume change was less than 10%, they got the treatment we talked about. If their volume change was greater than 10% in either group, then they went on to complex decongestive physiotherapy and were considered to have clinical lymphedema. Next slide.
Pat, we had a couple questions here. Tape measure actually is quite quick. Somebody in the audience said, I would love to time you. So, but maybe it is. I don't want you to get really good at it. Maybe it is quick.
This is Walt and Taylor. I'll make a comment on this. It's very quick if it's what you're set up to do, and that's what you're doing, and you're running patients through, and that's the way it is. The reason that, but in the common practice and the way we do it, setting someone in, putting them on what looks to be a scale that takes about 15, 20 seconds, and just running it through as though it's a vital sign in our world's much easier in a clinical practice. It just is. You're not, if you're lay an arm out, find your space to put them in, arrange them, position them. If you have a PT area where you're trying to put someone out, put their arm out, measure them, make it comfortable and position them, it's easy. But in a physician practice, it's not so much. You can just simply stand somewhere there, put on something like a scale, hold this. Okay, we're done.
Well,
That's
Walt,
really
in the SOZO LDEX model, it really is less than a minute. And whoever made that comment that tape measures really fast, I imagine it's a lot faster for some folks, but I don't see anybody doing it in less than a minute.
Someone made a comment, and I guess this is important to people. PT and OT trained practitioners can treat patients with the appropriated, that's what they said, appropriated term is, the appropriate term is complete decongestive therapy. I guess we call it decongestive physiotherapy, but I guess we need to talk the same language.
Well, that having worked with these folks, I love these folks, especially the physical therapists that I work with. That's a lot alike some of the things that we say differently from time to time, whether it's obesity or high BMI, CDT, CDP, so yes, there are different terms, but CDP is about as official as CDT.
Yeah.
But if that's what you use, then that's great. Either one. I think physiotherapy or therapy, it may be that if you're more from England and Australia. The bottom line here, and this is what we're showing in this slide, these are the results, and you rarely see something this dramatic a difference, especially when you're looking at sort of the best practice tape measurements you could possibly do, which is all we had and all the NCCN and other organizations could recommend for many years. The progression after a trigger to lymphedema was just shy of 20% in this group of patients in the tape measure group, and numerically less than a third that number, so 8% percentage-wise, 11% less. But if you just look at the number of patients that progressed on each side, 7 versus 23. 8% went on to lymphedema in the bioimpedance side of the trial. The other part of this that sort of makes you start wondering why and how is the number of triggers. And so more people had a trigger and intervention in the tape measure group than did in the LDEX group. Now, to me, you know, if you're just doing a traditional clinical trial analysis of this, you'd say, well, that means the tape measure is less specific. You're getting more false positives. And so you're doing more interventions. It's doing you no good because you're getting worse results. Pete and I were discussing this the other day, and it makes you wonder exactly why this is happening. It could be post-op swelling. It could be other things. But the bottom line here is you're getting a dramatically better result with fewer interventions.
Yeah, and you're going just an absolute number. You're going from over 5% patients that progress to CDP to 1.5%. So, I mean, it is a remarkable reduction in progression to CDP, because that's a tough, lifelong problem for those patients.
Well, and this is the kind of result that,
Thelma,
go ahead, Walt.
from about a facility that can't afford to buy an LVEX. And this is something that I hold, and Dr. Beitsch holds very dear to our hearts. He and I both sit there and work for a charity providing free cancer care to anyone that can't afford cancer care. We actually provide free surgeries, free office visits, free LDEXs to those people that can't afford their cancer care. We do the services for free here in Dallas. And it's a huge deal to us because we worry and stress. Actually, I'm putting on a big thing for the American Society of Breast Surgeons for industry, working on health equity. How do we make sure that everybody gets access to the care that they need? And the key to this is, how do we make sure that people can get access to this? And the SOZO units those are leased units for us. We lease those, we don't buy those. And they're a company you can talk to about this because they have ways to work this out to make it work for your facility. But at the end of the day, catching something preclinically before you get it with a tape measure makes a difference in an outcome. It does. And better care comes when you can catch something before it's clinically seen. And to me, it's such a health equity statement. That's why for patients who have no healthcare insurance, no access to anything, Pete and I still do it for these patients through our clinics because it's the right thing. And so I get it's, how do you get it? How do you make it happen? We found ways in our community to make this available to patients in North Texas. And it's hard to do, but we found ways to make it happen. And so I get there's a stressor there, but to me, it's such a big deal to do the right thing for every patient every time, and not just for patients in certain areas. And so I don't mean to sound like I'm on a soapbox, but it's sort of a big deal to me that we try to find the right thing to do the right thing for patients, the right way.
Yeah, we're going to talk about the economics in a minute.
Yeah, Walt's been doing this for a long time, and it was sort of at best a break-even proposition for many years. Fortunately, now in the last few years, this is something that will overall support your program, support your practice, support the things you need to keep the lights on and keep things going. It's a revenue positive now, whereas before, like I said, we sort of broke even, but we were convinced it was the right thing to do. Next slide. This is just graphics for folks who think more graphically. You can see on the left, there were fewer triggers to intervention in the LDEX group, but then on the right, far, far fewer patients went on to develop lymphedema, and suggesting sort of some false alarms, false positives in the tape measure group, but certainly nothing effective that reduced lymphedema. Next slide. This was something that was remarkable. Pete, have you ever seen this in any study?
I've never seen a plot like this before. Usually at least a couple of cross the one, but not here. Amazing.
So any of the subgroups, and believe me, this will give rise to a number of publications that focus in on some of these subgroups. In each subgroup, you saw a fairly dramatic reduction in the need for CDP or CDT. So next slide. The trial itself, the publication of the trial itself concludes that LDEX is more accurate for lymphedema detection than tape measure. I think that's patently obvious, and has fewer triggers. And that it identifies patients that are more likely to benefit from that limited intervention that the patient's got. We think this means that this is really should be a part of standard survivorship, just because a standard part of it, because it's so doable. It does not disrupt workflow. It pays for itself and more. And we really feel like it's incumbent on, you know, the doctors we know. The whole point is to make sure our patients are getting the state-of-the-art breast care. And this certainly suggests and shows that this is part of that. Next slide. There are a lot of great institutions that participated in this study. Sheila Ridner at Vanderbilt was the PI, but a number of other great places that we're all familiar with contributed, and I think everybody's grateful to these folks. Next slide. So, Pete, this is a meta-analysis that Chirag Shah, who had participated in the study, did, just looking at overall population numbers, and he did a meta-analysis of 50 studies over 67,000 women, and he found that in studies where LDEX was used, compared to studies where tape measure was used, the same sort of ratio, the same sort of differences had been reported for many, many years. It's just we did not have this randomized controlled trial evidence. So tape measure in the bioimpedance groups that were reported over the years in these 50 studies, 3% progression to lymphedema and CDP or CDT. And in patients who had measurements done, it was a progression on in 17%. And so we'll use those numbers, 3% and 17%, to do a little back of the envelope measurement here in a minute. Next slide. This is an old study. It was published in 2009, and it shows that when this is looking at commercial payer plans, when you look at total cost of care for cancer patients, and I think this is after surgery, if you look at total cost of care for those patients, if they developed lymphedema, their total cost of care was more, the increase from lymphedema was more than their actual cancer care treatment. And so it went up from $8,560 to $22,000, making the overall difference for patients who developed lymphedema $14,600. Pete, I think this has to be post-operatively, because I think my hospital charges $200,000 or $300,000 for breast cancer.
Well, you're worth it, Pat, in your hospital. I mean, we all know that. And this was in this study was 10% of the patients too that had lymphedema claims. So think about dropping that by at least by 2/3 down to 3% or less. So
next slide. If you do a little back of the envelope estimate, and you say, let's take 100 patients measured over 2 years, because that's what that study was done, measured, and you test them every 3 months for those 2 years. If you do, that's 8 measurements, they're $140 Medicare reimbursement a piece, and that cost is $112,000. If you look at the cost of managing those patients, that $14,600, if you have 17%, 17 of those 100 patients, that's going to be $248,000 and change. If you have the 3% group, that's going to be $43,800. And so the gross savings there, the gross difference is $204,000. Of course, you spent $112,000 getting there, but you end up with a cost savings for 100 patients of $92,000. And so an average of about $924 a patient. And the real point here, because I think you can run these numbers and get somewhat different numbers. The real point here is that we are in the US and worldwide, we're used to paying for increases, for improvements in outcome. We pay for chemotherapy. It would cost a lot less if we didn't do chemotherapy, but patients live longer and survive better. So it's the estimate is for every quality adjusted life year, a reasonable cost is $50,000. And that's sort of a surprise to me. But here is an approach that not only does it cost that $50,000 for a quality adjusted life year, it saves the whole system money. So it's one of the other extraordinary things, along with that forest plot where everybody's on the left side of one.
and it's the right thing to do.
Next slide. So this is the program that we have in our office, and I think many people do. And the setup is kind of interesting. You know, we test everybody when they come in, just as they're checking in at the check-in station. And we give them a compression sleeve if they do go up more than 6.5 points. That doesn't happen that often. But then we also have access to certified lymphedema therapists, and these folks see that lymphedema therapist if this happens, and she manages them at that point and generally sends them back with less than 6.5 increase from baseline. Pete, do you have a physical?
Yeah, so that's interesting. I mean, that's a real plus for your practice to have that available on site during every one of your clinics. We don't have that, but my nurse took a special interest in this and knows enough about how to put measure for garments. These are off the shelf, so she'll order compression garments off the shelf for these patients, and that's unless they and then we'll remeasure them after a month. Usually it ends up being about 6 weeks because it takes them a week to get into the store or the shop that sells the compression garment. But then once they get in them, we bring them back, and our practice is similar to yours in that 95+% of the time they're back to baseline. But if they're not, then we go on to other. We send them to a physical therapist. So 95% of the time we handle it just with our office staff without an additional physical therapist. That's a luxury that not.
We have physical therapists in our lobby that we refer to. We're lucky. We have them right there. So we use physical therapists for all of these patients and see them back in 6 weeks.
I think the key, the point, Walt and Pete, is just that you have a relationship with a physical therapist as needed. And so, and frankly, I think most programs that use this technology around the country, it's there in the physician's office or in the point of care, the intake office, and the patients also, if they get sent to the physical therapy department, whether it's, down the street or in the building, those folks also have a SOZO unit to measure the progress for those patients as they come in and get managed. Next slide. The recommendation is for every 3 months for the first 3 years, and this is why the majority, not all of it, this is why we continue monitoring, but the majority of lymphedema, if it's going to happen, will happen in the first 36 months.
Yeah, we did have a comment from the audience. One place does LDEX measurements every 3 to 4 months, but just for the first year, and then every 6 months after that for up to 5 years. And so, and I must admit, I fall off after year 2 to twice a year instead of 4 times a year. But unless they've been triggered and we've had to measure them, and then we bring them in, not necessarily to see me, but just to see my staff about that. So. Walt, are you bringing them in every 3 months for 3 years? Is that, and Pat, are you doing that?
I do every 3 months for 3 years. We do it quarterly.
Yeah. Pat, are you maintaining that schedule?
Yeah, I can't say that we do that for everybody. Certainly if we have people coming in every 3 months.
Well, yeah.
Over the years, we've started seeing some folks, and we kind of individualize, seeing those folks not at 3 month intervals for the first 3 years. We'll back down a little earlier than that, but I think the key here is to get this measurement every time they come in the door, every time they're going to see you, and then have a pathway for them if something gets picked up.
Yeah. Here's an interesting question, and I do not know the answer to this. LDEX, does LDEX detect chest wall, breast, or lateral torso lymphedema? Now that is annoying for sure. But it's not as necessarily as disabling as an upper extremity chronic lymphedema. But does LDEX? I don't know the answer to that. Do you, Pat? Do you know?
Well, we've had this question a number of times because it's such a bother. Those patients who get breast lymphedema, and that breast is swollen and often kind of reddish, and you think that does she have an infection? Some folks get that patch of lymphedema on their back, but this is only extremity measurements. Really, this is only giving us extremity.
Yeah, I'm getting texted. Yeah, it's just about extremity, not about the chest wall. But those are issues though. And did you use I think it's called the caterpillar? Do you use the sort of the furry animal that you put in the bra to do breast compression? Have you used that at all, Pat?
We don't have any furry animals, but my physical therapist does have some special material that she puts in that I think is active, like is what you're referring to.
Yeah.
The other thing about this SOZO technology, though, even though we're not talking about lymphedema in the breast or the shoulder or the back, it does comprehensive body composition now. So you're getting a readout on muscle mass, state of hydration, body fat, things that we think as the data gets developed over the next few years, we'll be using this for much more than that, probably for nutritional assessment, probably for bone mineral content. But at this point, the extremities are the focus for sure. Next slide.
Yep.
So the NCCN guidelines have for a long time said monitor for lymphedema. Unfortunately, without this technology, all we had was, okay, we found you've got lymphedema and we're sorry. And we're going to try to keep it from progressing. And it wasn't futile, but you certainly ended up with a fair number of patients with lymphedema because you weren't really preventing the development of lymphedema. You were just slowing progression or preventing progression once you found it. So much more attractive to be in a position to prevent that swelling from becoming permanent. Next slide.
I love NCCN guidelines. You know me.
Next slide. For the organizations that really focus on this, the American Physical Therapy Association has over 1,000 members, far more than most of the societies that we're part of. But for the organizations that really focus on lymphedema management and survivorship, every one of these mentions bioimpedance as part of the program they recommend for preventing or reducing the life impact of lymphedema. Next slide.
So Pat, there's another question that's interesting, and I have an opinion, but I want to hear yours. Are pre-surgical measurements crucial, given that there's a contralateral arm for comparison?
Yeah, pre-surgical measurements are not crucial because we certainly do this for folks who did not get a pre-surgical baseline, and there are all sorts of reasons that situation can come about. We think it's very valuable for folks who don't have a baseline. It's just that a baseline is a little bit better because some people start out with a negative number at baseline, and if you increase 6.5 points above that negative number, that's a trigger, right? And if you don't have that, and then you don't really know what that baseline was. That said, it's not that big of a disadvantage. It's just it's less than ideal, and it's less than best practice. But we're not living in an ideal world. No,
I understand, and it's better to do it after than not do it at all. But I would say I try to always get it pre-surgery because it gets them in the habit of thinking about lymphedema, that I'm going to do something to them that could cause it, and that we have a program in the office to try to detect subclinical lymphedema and fix it before it's a real problem.
And that's the same.
I like getting it pre-surgery because it gets them in a frame of reference.
And we do the same thing. Matter of fact, our surgery scheduling sheet has a stop on it that they can't get scheduled for lymphatic surgery until they have an LDEX, because it forces the issue of them being aware that this is a real issue.
Yeah.
It's a real complication, and that they need to think about this and get it done. It's one of our sort of safety checks. We sort of have this concept of a culture of safety and preventing errors and preventing problems. And lymphedema is something that you can prevent. And so we have this as a stop on our surgery scheduling sheet, and the patients know they have to have it done. They get a surgery scheduling sheet and it says what their LDEX is. And that's part of that, setting the mindset of this is a real risk, and it's something that is really preventable in some people. And so that's sort of part of our culture of safety.
This slide just sort of summarizes the conversation we have with the patients. And they get it immediately. Many of them will come in saying, you know, I'm not going to have don't touch my lymph nodes because I've heard of lymphedema and it's worse than cancer. But we are able to reassure those patients that we have a way of mitigating that risk. And I think 2 or 3 people have pointed this out in the survivorship mode and trying to manage folks' survivorship so that they get on with their life and they're happy just doing this. It reassures patients that we expect them to be around for a long time. It's reassuring to them that we're planning, you know, for their future anyway.
Yeah, and Pat, while we're on this slide, I did want to emphasize the workflow issue of this. You know, for a while when we were having to do, remember 10 years ago probably, when we were having to do ABNs for Medicare patients and have to discuss with patients whether we were going to charge them or not, blah blah blah. When they were using the sticky, what are those called, in the previous system. But now with the SOZO unit and leasing it, and I mean, it probably varies a lot, but you know, we do it. Everybody gets it done, and the only people that really refuse are the ones that remember the ABNs from the past, where we were going to charge them. So you know, it's just it's in our workflow, and at least in my office, and I want to hear what you have to say. They get it done before I see them, so that I can discuss with them if they have an abnormality what we're going to do.
Well, and along with other vital signs too. So,
Yeah.
you know, I think you and Walt pointed this out to me a few years ago. I had this in the physical therapy area, and it turned out I was missing about 2/3 of folks that needed it. So
Yeah.
I'm absolutely convinced that's true. And now that, you know, the issue has kind of gone away to a large extent. So there's universal coverage by Medicare and pretty universal coverage by private insurance, with the exception of one insurance company that's sort of always last to bring this kind of advance to their patients. But they're
No, I don't see color, but are they blue?
Yeah. Well, that we will see. I think we will see them turn around before long, because there are advocates for women that with this kind of randomized controlled trial data can say, you know, this you better not be treating women like this. Next slide.
Yeah, let's talk economics.
Yeah, so Medicare reimbursement. And I think this is pretty solid all around the country. There's not really an exception. This number varies a little bit, but it's $140 per test. And the diagnosis codes that support that procedure that you see here on the left. There are a lot of, and as everybody on this webinar is a practicing provider knows, there is an art to coding and billing. And one of the things that's very, very helpful here is having a template that explains what you're doing and why you're doing, and you don't have to dictate this every time and remember all the elements. So one of the things we strongly recommend is having a template in your EMR that is essentially automatic with this. Pete, do you use something like this?
Oh, absolutely. And again, my MA, not even my nurse, my MA does all the LDEX measurements and fills out the template. So it's actually in my EHR she bills for it on the billing columns. I just wanted to point out the CPT code 93702, well established, been around for a while. The reimbursements are robust for this. So I know there's a lot of people questioning whether it's worth it. It's worth it for the patients to prevent, you know, chronic lymphedema, stage 2 and above, but it's actually worth it for the practice too. So it's a win-win-win, really. Next slide.
This was a big breakthrough for a lot of places. The company Impedimed got very frustrated with doctor after doctor telling them, you know, I'm convinced that my patients need this. I want to provide it for my patients, but I'm getting all these denials. I'm getting my billing office is just about to, you know, tie me up in my office. How am I going to succeed at this? And the company finally established a case assistance program that is really unique. I don't know that we've seen this sort of an effort. I guess when there are, you know, if you have a drug that you are providing for cancer patients and it costs, $30,000 a month or whatever it costs. There are a lot of programs like this for things like that, but this is, I think, to me, that is in the device world, this is pretty unique. But the company will establish a compliant, HIPAA compliant connection with your EMR. They can't write things in there, but they can read that. And the company will do the pre-search. They will go through the appeals process. They will manage this in a seamless way, providing the documentation that's needed by anybody that denies it, so that your workflow is not everything, but it can sure stop everything. So this makes your workflow pretty much seamless. And since this program has been implemented, in the cases they take to appeal, they have about a 99% success rate, even in cases that aren't in appeal. If you put all those cases together, the pre-search, the appeals, this is a very successful program. Again, there's one insurance company that's yet to come around, but frankly, in my practice, that really doesn't matter. It's already substantially in the revenue positive category.
Let's take a look at that.
All right.
Next slide.
So if you'll follow these recommendations, if you are convinced, and this is what really got us there, we were convinced that this is something our patients need, that this is best care, and that patients deserve this. So these are the sort of simple steps we took. Put it in your check-in station, test every cancer patient. The provider can decide at the end of the encounter whether that patient was an exception, that maybe didn't really, maybe they had a lumpectomy and nothing else, that maybe didn't need it. And then the provider can decide not to charge for it if it wasn't necessarily indicated. On the other hand, you do need a relationship with a certified lymphedema therapist. You will be very glad, your office manager will be very glad, your billing office will be very glad to have the case assistance program working in concert, especially if they have HIPAA compliant access to the EMR. Now, this is a bit of a dicey subject, because some people, when they hear this, think, well, this might be illegal or it might be against the law. But I can tell you, we strongly recommend, in my practice, this is what we do. And the company, I think, is not in a position to say something like this, although they can say, you may want to consider it if you check with your compliance office. We tell patients, if your insurance company denies this, and it's rare that happens, but if your insurance company denies this, we're not going to charge you. We're going to write off that cost. Now, if your insurance company covers it, yes, you have to pay your deductible, and we are charging every insurance company. We're not deciding who to charge and who not to charge, but legally, that's the right thing to do. In fact, if you charge a Medicare patient after a denial, it's illegal unless you got an advanced beneficiary notice. And I can tell you, trying to work that into your workflow will just totally sink your program. Pete, you've had that experience, right?
Yeah, it didn't, we tried it for a while, early on, because we were early believers, but yeah, it doesn't work. And I don't get AVNs for anything anymore.
It's
so question.
Yeah, go ahead.
This one audience participant said, in our setting, the nurse practitioner does the initial consultation and they do the LDEX. The physical therapist gets referrals from the nurse practitioner. Who can technically bill for the LDEX? Can nurse practitioners, physical therapists, or just the physician?
Well, it depends. Those folks have to be credentialed with the insurance company. But if the nurse practitioner is in the office with you and you're on site, that is generally billed as incident to your care. And so that is billed under your name. If you're out of town, then it's going to be billed under her name. And the same thing would be true with the physical therapist. At least that's our practice. And anybody who's credentialed with the insurance company can make that bill. Now, certain, I think Medicare and Blue Cross have a discount if it's the nurse practitioner or the physical therapist, but I think anyone can. It's just, it makes more sense if you're in the office to bill it as an incident to event.
Yeah, agreed. How has it worked in your office for collections?
Pete, I'm glad you asked that. We included a slide here because we wanted to be able to show that this is a revenue positive event. So here's our last slide, but we'll talk a little bit about this. I just looked at one quarter last year and where this sort of sat on our revenue table, and it's up there. If you you talk about procedures and not necessarily office visits, it's probably in the top 5. But this was a 1 quarter, so that's if you annualize that, it's about $60,000. And I can tell you it does not cost that much to provide this service, nowhere near it. So, you know, whereas in the past, people struggled to provide it and just to do the right thing like Walt was doing, and like Walt and Pete did, we all kind of did for a long time. Now that reimbursement has expanded to just about every carrier that has a conscience, it's a very revenue positive event. You've seen the same thing, right, Pete?
Yeah, and it's even in my practice, which is not nearly as breast cancer volume as yours, but I do have a lot of melanoma patients. I think we're right on that. I think we're a little above that, because I see all my melanoma patients in follow-up forever, you know. Yeah. And I think it's around $70,000 per year, and my expenses are not even half that. So it's a revenue enhancement for the practice, and if you're an employed physician, it's a revenue enhancer for the system. And the bottom line is it's the right thing to do.
Well, you're in a big program. I mean, you're in a big group, a big multi-specialty group, right? Did your billing office or your group have any objections to how you provide this?
Not in the least. And it's, I mean, it makes money and it doesn't take that much time, and it's the right thing to do. So it's a win-win-win, and nobody has ever really objected to it once they see the data. So,
Walt, is that true in your big group?
Our group is a little different. I work for a system that is massive, and they struggle with this a little bit. We're trying to work towards it, but we've had no true billing and collecting. They're pretty good at, and so we've only had one real trouble with one real person paying us, and that, of course, I don't think I'm allowed to say who it is, but again, I guess
it looks a lot like the Pat's slide here, really.
Yeah.
The blue colors make you think about it.
Yeah, it does for some reason. Yeah.
Yes, it does.
Anyway, I think they'll be coming around before too long. It's a woman's advocacy issue for sure.
For sure. Well, we are within 2 minutes of being done, so I've hit not all the questions, but I hit quite a few of them. Pat, can gynecologic oncologists and specialty groups charge for this procedure?
Absolutely. There's not a specialty specific restriction on this, and I think if you'll need a different you'll need a different template maybe, and you might. But if you're all of the things you mentioned are at risk of causing serious lymphedema, lower extremity, so no, I think any specialty that causes lymphedema ought to be using this.
For sure.
I have just a quick aside. There's a doctor in Dallas who does melanoma like I do and Pete does, and she doesn't do this. And she's like, do you mind? I don't really want to put the device in my office. It's just, I don't really see much lymphedema. But if I see a patient who's got some swelling, do you mind if I send them to you? And I see one about every other month with stage 1 or stage 2 lymphedema in the lower extremity, where we don't ever see stage 1 or stage 2 lower extremity lymphedema because we measure our patients with an LDEX, and hers come a little too late. And it's one of those early detections is the key.
Okay, I think we are within a minute. I don't, Pat, give me your elevator pitch for LDEX and tell me about the PREVENT trial.
Well, from a personal professional point of view, I'm glad that we're finally at this point where this is recognized as best practice, and we have randomized controlled trial evidence of that. So there's just not really any arguing with that. People used to say, well, I've got this objection or that concern. That's over. This is proof.
And Walt, you get the last question from the audience, which is it useful for following the progress of lymphedema with treatment, or only for early detection?
It is. It's not perfect. If someone comes to see you with already stage 2 lymphedema, you've already got fibrosis, you've already got things that aren't going to change, but the subtle fluid levels, you'll see changes. And it turns out there was a great trial looking at patients who had chronic lymphedema who did home monitoring. And those that did home monitoring with an LDEX device actually had better control because it stayed top of mind. They did the things they needed to do to stay better. And so there is a benefit to it, not nearly as pronounced in trying to detect preclinical, but there's still a benefit to following patients.
Perfect. I want to thank everybody for attending. Almost everybody stuck around to the end, Pat. How about that?
That's good. Well, thanks, Pete.
If you have any questions, I think you can contact, you probably have a link and hopefully an email or something. I don't know that. Joanne, I hope that's true. Or you can always email me or Pat or Walt too. We'll be happy to hook you up, because this is a personal issue for all three of us to really help improve care for women in America. Without further ado, enjoy your evening.
Yeah, enjoy your evening.